HG, like 160 millimeters.
Hey, tell me again. I don't understand the difference. Give us an example of FI and partial oxygen.
FiO2 is the oxygen percentage in air you breathe. Partial pressure, PO2, is oxygen's pressure in that air. Example, room air has FiO2 of 21%, 0.21. At sea level, total pressure is 760 millimeters per Hg, so PO2 equals 0.21 times 760 equals 160 millimeters per Hg. In lungs, PO2 drops to 100.2 mHg. FiO2 sets how much oxygen, PO2 is its push. Clear?
But what do we mean by its push? Its push, how does it push and what does it push?
Partial pressure, PO2, is the push oxygen has to move from air into blood or tissues. Higher PO2, like 160 millimeters in air, pushes oxygen into lungs on 100 millimeters per Hg, and then blood, 100 millimeters per Hg. It's the force driving diffusion across membranes, not physical shoving. Clear?
Alright. But doesn't the push relate to the oxygen percentage?
Yes, exactly. The oxygen percentage, FiO2, directly sets the partial pressure, PO2. FiO2 of 21% in air, 760 millimeters per Hg total pressure, gives PO2 of 0.21 times 760 equals 160 millimeters per Hg. Higher FiO2, like 50%, means higher PO2, 0.380 millimeters. More push for oxygen to move into blood. They're linked. Percentage determines pressure. Got it?
Okay. Let's talk about traditionally dividing lung problems to airways and alveoli and why we went away from that.
Lung problems were traditionally split into airway, EXI, asthma, COPD, narrow bronchi, and alveolar, EXI, pneumonia, ARDS, damaged air sacs. Airway issues block airflow, EXI, allo, impair gas exchange. We moved away because many diseases, like COPD or cystic fibrosis, affect both, and the split oversimplifies complex interactions. Now, we focus on specific mechanisms, obstruction, restriction, or diffusion defects for better diagnoses and treatment. Clear? Want examples?
No, that makes sense. Why don't we talk a bit about emphysema?
Emphysema is a type of COPD where alveoli, air sacs, get damaged, losing elasticity. Walls break down, reducing surface area for gas exchange, causing low oxygen, hypoxemia. Airways collapse on exhale, trapping air, leading to shortness of breath, caused by smoking or genetics, alpha-1 antitrypsin deficiency. Treatment, bronchodilators, oxygen, lifestyle changes. Affects both airways and alveoli, showing why old divisions blurred. Want more on symptoms or progression?
So emphysema alveoli are inflamed and alveolar walls are destroyed.
Not quite inflamed, but yes, in emphysema, alveolar walls are destroyed. The alveoli lose elasticity and break down, forming larger, floppy air sacs. This cuts surface area for oxygen exchange, causing hypoxemia. No major inflammation like in asthma. It's more about tissue loss from smoking or genetic factors. Airways also narrow, trapping air.
Okay, but in chronic bronchitis, they don't get destroyed, the walls.
Right. In chronic bronchitis, another COPD type, alveolar walls don't get destroyed like in emphysema. Instead, airways are inflamed, thickened, and produce excess mucus, narrowing passages and blocking airflow. Some alveolar damage can happen over time, but the main issue is airway obstruction, not sac destruction. Clear? Want to compare more?
I want to ask you about blue bloaters and pink puffers.
Blue bloaters and pink puffers are classic COPD descriptions. Blue bloaters, chronic bronchitis, cyanosis, bluish skin from low oxygen, bloated from fluid retention, chronic cough, mucus. Pink puffers, emphysema, pink skin, thin, barrel chest, heavy breathing, less cyanosis due to hyperventilation. Terms are
What do we
outdated.
mean by productive cough in blue bloaters, and where does the names come from? How do they relate to structure and function?
Productive cough produces mucus or phlegm, unlike dry cough. In chronic bronchitis, blue bloaters, inflamed airways make excess mucus, causing wet, productive cough. Emphysema, pink puffers, has less mucus, more alveolar damage, so cough is often dry. Names: blue bloaters from cyanosis, blue skin, low oxygen, and edema, bloating. Pink puffers from normal skin color and pursed lip breathing, puffing. Structure function: bronchitis thickened, mucus-filled airways block flow. Emphysema destroyed alveoli, cut gas exchange, increase air trapping. Clear? Want more on symptoms?
Well, I want to understand pink puffers and blue bloaters more. Their differences, how the names come from. What's puffing?
Pink puffers, emphysema, named for pink skin, better.
Hey, keep going.
Puffing in pink puffers, emphysema, refers to pursed lip breathing, where patients.
Oh, guys,
All right, my bad.
Grog's a bit slow today. Let me restart. Grog, guys, just to say. AI. We've come to a new generation. Okay. Yo. Okay, Grog, let's continue kind of comparing blue bloaters, pink puffers. What are puffers? What does puffing mean? Maintaining, and how does puffing help maintaining airways and alveoli open?
All right, let's compare blue bloaters and pink puffers. Zooming in on puffing. Pink puffers, emphysema, named for pink skin, less cyanosis, hyperventilation keeps oxygen up, and puffing, pursed lip breathing. Damaged alveoli collapse airways on exhale, trapping air. Puffing, exhaling through tight lips, creates back pressure, keeping airways open longer, reducing collapse, improving air exit. Thin build, barrel chest, dry cough. Blue bloaters, chronic bronchitis, named for cyanosis, blue skin, low oxygen, and bloating, edema from heart strain. Airways inflamed, mucus clogged, causing productive cough, less alveolar damage, no puffing. Breathing is labored, but not pursed lip. Structure function: emphysema, airway collapse, low gas exchange. Puffing counters collapse. Bronchitis, mucus blocks airways, no puffing needed. Mucus is the issue. Clear? Want more on how these affect lung function?
Okay, let's talk about restrictive lung disease then. So restrictive, we have also talked to us about kyphoscoliosis and loss of lung. And so restrictive means that we have a problem with exhaling because there's trapped air, right?
Not quite. Let's clarify restrictive lung disease. Restrictive lung diseases limit lung expansion, making it hard to inhale enough air, not exhale. Unlike obstructive diseases like emphysema, where air is trapped due to airway collapse, restrictive issues come from stiff lungs or chest wall. Examples: kyphoscoliosis, spine curvature restricts chest movement, or interstitial lung disease, lung tissue scarring. Problem: low lung volume, reduced total lung capacity, hard to fill lungs. Exhalation is usually okay. Air isn't trapped. Causes fibrosis, neuromuscular disorders, or chest deformities. Symptoms: shortness of breath, rapid, shallow breathing. Structure function: Stiff lungs or rigid chest wall cuts expansion, lowering oxygen intake. Clear? Want examples or how this differs from obstructive?
No, makes sense. And let's touch a bit about the right to left shunt to venous admixture.
All right, let's hit right to left shunt and venous admixture. Right to left shunt. Blood bypasses lungs, flowing from right heart to left without oxygenation, e.g. in congenital heart defects like tetralogy of Fallot or lung issues like ARDS. Deoxygenated blood mixes with oxygenated, lowering arterial oxygen, PaO2. Venous admixture, similar effect but broader. Any mixing of deoxygenated blood into arterial blood, like from shunts or poorly ventilated lung areas, e.g. pneumonia. Both cause hypoxemia, resistant to oxygen therapy. Shunt is anatomical. Admixture includes functional issues. Clear? Want more on causes or effects?
No, that's good. Why don't we talk about VQ mismatch and give an example of, let's say, pneumonia?
VQ mismatch is when ventilation, V, air to alveoli, and perfusion, Q, blood to capillaries, don't align, impairing gas exchange. In pneumonia, alveoli fill with fluid, or pus, blocking air, low V, but blood flow Q continues. Result, blood passes unoxygenated areas, causing hypoxemia. Example, right lung pneumonia, affected lobe gets less air, but blood still flows, mixing low oxygen blood with arterial blood, dropping PaO2, fixed by oxygen therapy or treating infection. Clear? Want more examples or fixes?
Interesting. Why don't we talk a bit about pulmonary fibrosis too?
Pulmonary fibrosis is a restrictive lung disease where lung tissue scars, stiffening alveoli. This cuts lung expansion, reducing air intake and oxygen diffusion, low PaO2. Causes: idiopathic, autoimmune, or environmental, e.g. asbestos. Symptoms: shortness of breath, dry cough, fatigue. VQ mismatch can occur if scarring blocks air but not blood flow, like pneumonia. Structure: scarred, thick alveoli, lower gas exchange. No cure, treatments, steroids, oxygen, slow progression. Clear? Want more on VQ and fibrosis?
Yes, please. So it's scarring and thickening of the tissue, basically.
Yep, exactly. In pulmonary fibrosis, scarring and thickening of alveolar walls stiffen lungs, cutting air intake. For VQ mismatch, scarred areas get less air, low ventilation, but still have blood flow, normal perfusion. Blood leaves these alveoli poorly oxygenated, mixing with arterial blood, lowering PaO2, hypoxemia. Worse in severe fibrosis, where more alveoli are scarred. Oxygen therapy helps, but mismatch persists until scarring is managed. Clear? Want specifics on treatments?
No, that's so good. But I do want to talk a bit about AA gradient. Explain us the AA gradient. What's the difference between AA gradient and, let's say, VQ mismatch? I don't get it.
The AA gradient, alveolar arterial gradient, measures the difference between oxygen and alveoli, PaO2, and arteries, PaO2. Normally, it's small, 5 to 15 millimeters of mercury, as oxygen moves efficiently from lungs to blood. Calculate. PaO2, estimated from FiO2, atmospheric pressure, and PaO2 minus PaO2, minus PaO2, from arterial blood gas. High AA gradient means impaired oxygen transfer, like in VQ mismatch, pulmonary edema, or shunts. VQ mismatch, uneven ventilation perfusion, e.g., pneumonia, fibrosis. Some alveoli get air but no blood, or vice versa, raising AA gradient by mixing low oxygen blood. AA gradient is a number showing the oxygen transfer gap. VQ mismatch is a cause of that gap. Gradient quantifies, mismatch explains why. Clear? Want an example calculation?
Explain this to me a bit more.
AA gradient is the gap between oxygen and alveoli, PaO2, and arteries, PaO2, normally 5 to 15 millimeters per Secchi. PaO2 is calculated FiO2 divided 760 minus
No, I'm a
47
bit confused about the
minus
difference
PaO2,
between. Hey,
0.8, where 760 is
Sir.
atmospheric
Oh,
pressure,
guys, it's
47
still
is
again.
water vapor pressure.
Oh no, guys.
PaO2 comes from arterial blood gas. Big gap.
Sorry, guys. I don't know why this is happening. Hey, dude, I'm just a bit confused between AA gradients and VQ mismatch. Like AA gradient, we have a difference in alveolar and arterial, right?
Yeah, you got it. But Yo, I heard you talking
No,
another
I
language.
didn't talk another language. Okay, tell me again.
My bad, got it, sticking to English. AA gradient is the difference between alveolar oxygen, PaO2, and arterial oxygen, PaO2, normally 5 to 15 millimeters. High gradient means oxygen transfer sucks. VQ mismatch, like pneumonia, is when air and blood flow don't match in lungs, causing a high AA gradient by mixing low oxygen blood. Gradient measures the oxygen gap. Mismatch is why the gap happens. Clear? Want a quick example?
Yes.
Cool. Normal AA gradient. PaO2. Alveolar oxygen, say, 100 millimeters. Minus PaO2. Arterial oxygen, 90 millimeters. Equals 10 millimeters. In pneumonia, VQ mismatch, alveoli get fluid. So PaO2 stays 100 millimeters, but PaO2 drops to 60 millimeters. Gradient is 40 millimeters, showing poor oxygen transfer due to mismatch. Clear? Want another?
Can you give me an example to see if I understand? I mean, give me, like, do some Socratic questioning to me.
All right, let's do some Socratic questioning to check your grasp. Imagine a patient with pulmonary fibrosis. Their PaO2 is 100 millimeters, but arterial PaO2 is 70 millimeters. What's the AA gradient, and what might cause this gap? Go for it, and I'll guide you.
I have no clue.
No worries, let's break it down. The AA gradient is PaO2 minus PaO2. If PaO2 is 100 millimeters and PaO2 is 70 millimeters, what's the difference? And think, why might oxygen not move well from alveoli to blood in pulmonary fibrosis? Give it a shot.
I don't know, dude.
Oh my. All right, no stress. Let's walk through it. AA gradient, PaO2, 100 millimeters of power, minus PaO2 minus 70 millimeters. What's 170? For pulmonary fibrosis, why might oxygen struggle to get from alveoli to blood? Hint, what's happening to the alveolar walls? Try again.